Musculoskeletal pharmacology, or what those of you in the colonies would call musculoskeletal. So there's many different elements of musculoskeletal pharmacology. Pain and pain meds are the one we're going to spend the most time on, mostly because of the great interest in opioids most recently. We'll talk about opioids in a number of different ways. I've also got a number of different alternative videos for you to watch. There's one on endocannabinoids for pain as well. I think that right now there's not a lot of understanding of the pharmacology of the endocannabinoids. We'll continue to work on that as time goes on, but it is something that you will want to make yourself familiar with because a lot of patients are trying it. The second talk, we'll talk more about osteoporosis, rheumatoid arthritis, and some of the other elements of musculoskeletal pharmacology. So every stimulus that you experience has both objective and subjective components. So it's not just an objective phenomenon, it's also the person experiencing it that is critical to think about. So when someone has some kind of a noxious stimulus, nociceptors are stimulated, bradykinin and prostaglandins are secreted, usually histamine, potassium, and hydrogen ions as well. When those things happen, neurotransmitters are stimulated, and usually if it's pain, the two major kinds of neurotransmitters that are stimulated and the tracts that are stimulated are what the scientists call the A delta fibers and the C fibers. Very different kinds of pain are mediated by these fibers. This is why someone with chronic pain does not have an elevated pulse rate, does not have the usual things that we think of that they should be having with acute pain. So with A delta fibers, the phenomenon is a myelinated element. In a myelination issue, what happens is the nerve impulse jumps along the myelination and goes more quickly because of the myelination. Because of this, you'll have a sharp, well-defined pain. Patients will experience usually what we think of as pain, to the point where usually if it's a C fiber issue, some patients don't even describe this as pain. They say, well, it's an ache, it's not really pain, and it takes much longer for the fibers to carry these impulses of pain. Sometimes it's a burning, aching pain. Sometimes it's perceived in a different way. But usually it is still thought of as pain. So the limbic system up here is in the brain. And basically the limbic system is what regulates your emotional and cognitive responses to pain. And so we can impact that limbic system with a number of different medications. But it really comes down to what the patient is experiencing for the emotions that are associated. And oftentimes these emotions are related to previous experience and their current situation, as well as the cognitive elements, which are important because whether someone is going to lose work or have other issues, it is going to very much affect their perception of pain. Referred pain is a very different thing. Referred pain is when you have a pain that happens that normally would have been picked up by nociceptor A. The problem is that once it gets into the spinal tract perceives that it's actually coming from nociceptor B. So therefore you have pain in your heart, and the problem is perceived as pain in the arm. So pain that shoots down the right arm, left arm, somewhere else, and that is what referred pain is. So what does the body do when pain occurs? Well, pain is your friend. Pain tells you that there's a problem. Pain tells you to withdraw from that noxious stimulus. The problem is that if pain lasts too long, it's no longer your friend. It's actually causing problems. And the body has developed a system to mediate and modulate that pain perception. Now it produces something called endorphins or enkephalins that basically go and get into receptors that we think of as opioid receptors, and this will blunt or numb the sensation of pain. We call them opioid because they're similar to opium, and the chemicals that we derive from these poppies gave us this pain relief. There may be other chemicals which mediate pain, and as we know, antiprostaglandins and a number of different things do. But one of the others that is being experienced by a lot of patients and researched more are the endocannabinoids. And there is some information that there are cannabinoid receptors and that there are specific chemicals within the body that do stimulate these receptors, and that like using an exogenous substance like that derived from poppies, that we can create exogenous substances which will stimulate those same receptors. Essentially, for a chemical to work in the body, there has to be a receptor for it to connect to. So signs of pain, signs are basically physical changes that you can see. So pulse rate that goes up, blood pressure that goes up. And so the symptoms are things that the patient reports to you. So those are subjective phenomenon. And obviously we talked about how the pain is very differently perceived in acute versus chronic. Chronic pain, they have very different signs. And then somatic and visceral. Somatic because there's far less receptors. They often will perceive it as a dull ache as opposed to a sharp pain. I'm sorry, I meant to say that that's how they'll perceive it when it's visceral. Somatic pain, there's lots of receptors, aren't there? In your hands, various parts. Now, this is a statement that can get us into all kinds of trouble. And in the 1970s, there was a woman by the name of Margot McCaffrey, and Margot went around the country trying to make people aware that we were under-treating pain, that patients were suffering unnecessarily, and that we should help them. And so one of the things that Margot said, I actually heard her say this at a conference in Manchester, New Hampshire in 1978, was that pain should be accepted as whatever the person says that it is. The problem with that is that we now have a number of patients who have become addicted to opioids because we were trying to treat their pain. I'm not sure that Margot would say that every patient needed opioids, but I do think that she would still advocate for the point that if a person says they're having pain, that they're having pain. What we do about that is really up to us as individuals and as a society. So pain meds, opiates, as we know, there's an addictive potential. I think we're going to find that some people have a receptor which develops that euphoria and some don't. It does seem that people, when they're in pain, that the opioids are taken up by those receptors, and that even when people who normally get that euphoria sensation are in pain, they don't seem to get it. Most opiates are actually pretty safe drugs. They don't cause a lot of problems. There is some respiratory depression. There is some GI constipation. But unfortunately, they are very safe drugs until they are not. And that's the challenge. There's a big argument in regards to the use of opiates for long-term pain. I think everybody is in pretty good agreement that for short-term pain, intraoperatively, perioperatively, that they're really the gold standard. On the other hand, how quickly we should transfer people to non-opiate medications is a great challenge. If you've got somebody that's just had knee surgery, You want them to be able to move. You want them to be able to not get pneumonia. You want them to be able to do their physical therapy. But where's the sweet spot? What's the point at which we should switch them over? Very challenging to decide. Pseudo-addiction is a concept that some believe in and some do not. Basically, this is the patient who acts like they are a drug seeker. This is the patient who runs out of their pain medicine sooner than others. This is a patient that calls up and asks for more medication. This is a patient that seems to be very dysfunctional. The research that's been done that I've seen seems to suggest that if you can fix these people's issue, use epidural steroids for their back, that 50% of them, their pain goes away and they don't ask for any more medicines, that they really were not drug seekers. They weren't looking for a high. They were looking for pain relief. The problem is that there's no good way to know which ones are the 50% that were seeking pain relief and the other 50% that were seeking a high. So it is important, though, I think, to keep in mind that some of these people might have that pseudo-addiction phenomenon in which they are really just looking for pain relief, even though their behaviors become pretty dysfunctional. There's some other opiate-like drugs which we do need to be aware of. Tramadol does hit a number of different opiate receptors. It actually also hits a lot of serotonin receptors, and that's particularly important to remember, because if you have a patient that's also on a serotonin medication, you can end up with a serotonin syndrome. I actually had a woman come in yesterday who is on 60 milligram of Prozac a day. She actually had gotten a little bit of tramadol and a triptan on top of it, and triptans also have serotonin-like effects. She was feeling antsy, she was feeling anxious, stressed, blood pressure was up a little bit. These are all signs consistent with serotonin syndrome, and that's something that you do need to be aware of with tramadol. Loperamide, which is Imodium, which is used for diarrhea, also has some opium-like receptors that it hits, the ones that usually cause constipation. Interestingly, there's a small percentage of patients that do get almost like a high from taking a lot of Imodium. Usually takes them 50 or 60 of them to get that high, but there are people out there that will abuse this medication as well. Suboxone and methadone are used for maintenance. They have less euphoria. They seem to keep people more functional. They fill those opioid receptors so the patient doesn't go through withdrawal. It's a challenge to know exactly the appropriate role for these. Most folks that do addiction medicine really feel like medication-assisted treatment, which includes these medications, is far more successful than cold turkey or trying to get people off too quickly. Sometimes people can taper down off the methadone over time. Suboxone is more of a fixed dose, so it's a little bit harder to do that, but that is something that some people are trying to do as well. Other pain medications include the NSAIDs, the non-steroidal anti-inflammatory medications. There's some of these that are more selective for certain receptors than others. We'll talk about that in a minute. There's families of NSAIDs. That's not something that a lot of people pay attention to. And to be honest with you, I'm not sure if we need to, but it is something you should be aware of. They have a lot of GI side effects. NSAIDs affect kidneys and stomachs. They do not particularly affect the liver, except the medication Diclofenac, which is also known as Voltaren. Cardiac side effects are possible. There's a lot of interest in the increased incidence of myocardial infarctions in people that are on NSAIDs, and especially certain NSAIDs. This is one of those things that unfortunately makes the whole opioid thing that much more complicated, is that a lot of people say, well, just take an Advil. Well, the problem is somebody has substantial damage to their kidneys. You're taking a big chance by giving them Advil, Aleve, or any of the other NSAIDs. COX-2, and there's some other of the talks that are on here that really do talk about the COX-1 versus COX-2. I'm going to let them cover that. The COX-2 are supposed to have less GI side effects, and they do seem to. Relafin is a COX-2 at low doses, but once you get to higher doses, it's actually more non-selective. Basically, they block that COX-1 in most of the medications, which also slows production of thromboxane A2, which is prothrombotic. So theoretically, the COX-2 should have less risk of heart attack. There's some evidence that they actually may be more thrombotic than some of the other NSAIDs. There are theoretical risks of NSAIDs in cardiovascular disease. Most of the data suggests that these are relatively modest, but it's something to keep your eye out for. So the NSAID family. So the one that we use mostly, the propionics, which is ibuprofen and naproxen. So that's Advil and Aleve. Ketoprofen is also available, used to be sold as Arudis. Oxyprosin, which is Daypro, which is a longer acting, is also available. We did use this regularly for a while. We really did seem to feel like naproxen was probably long enough acting, though, and we like to give the organs a little bit of a break. Other NSAID families are the salicylates, which includes aspirin, salsylate, and some of the other things that have salicylate in the name. The acetic acid NSAIDs, which are Lodine, Diclofenac, and Toradoll. The problem with Toradoll is that it can damage the liver, as the other acetic acid NSAIDs can. Unfortunately, if you use it orally for any period of time, the side effect profile is actually pretty high. It's a medicine that is available in an injectable form. It's really great for anybody that has either a gallstone or a kidney stone. And a lot of people feel like it's almost diagnostic, that if you have a patient that has kidney stone type pain and you give them an injection of Toradoll and it goes away, that it really is diagnostic that it is probably a kidney stone. The phenamates, the meclofenamate is a medicine that's sometimes used for menstrual issues. The oxycams, piroxicam and meloxicam, are longer acting. Some people switch to these as something different to try rather than the propionics. I'm not sure that there's really any evidence that suggests doing that, but it is conceptually something that you could try. Another pain medicine is Tylenol or acetaminophen, sometimes abbreviated APAP for its chemical structure. It has no anti-inflammatory effect. It is not an NSAID. It is not a non-steroidal anti-inflammatory because it has essentially no anti-inflammatory effect. It blocks COX-2 only in the CNS, and so it really does block the pain pathway. The Tylenol people, the brand name Tylenol people, suggest that you limit it to no more than 3 grams a day. Most of the pharmacology texts say no more than 4 grams a day or 4,000 milligrams. I tend to err on the side of the 3,000 just because I'm afraid that somebody will bring up the Tylenol recommendation if there's ever a side effect or a problem. Generally, we avoid giving it to people with active hepatitis C infection. Fortunately, now that hepatitis C is curable, that is much less of an issue because we just get those people in, get them cured, and then we can go back to using normal doses of acetaminophen. Other pain meds, it's important to know that there's 2 major types of local anesthetics. A lot of people talk about Novocaine. Novocaine is almost never used, even in the dental offices. Usually lidocaine or carbocaine are what's used in a dental office. In the emergency department, we tend to use either lidocaine or bupivacaine. Bupivacaine is used when you want a long-acting effect. So the lidocaine kicks in about 10 minutes, lasts a couple of hours. Make it last a little bit longer by adding epinephrine to it, although we have to avoid fingers, toes, penis, and nose just because of the decreased potential blood flow. the plastic surgeons and some other brave folks are going ahead and using it, but you should be aware that those are sites in which the use is controversial at best and probably best avoided early in your practice. Novocaine is an option if you have somebody who has a lidocaine allergy and you're worried that they're going to be allergic to all of the other elements in that local anesthetic family. I will warn you, it's pretty hard to obtain. Other topical medicines like capsaicin, menthol, those kinds of things are used aggressively. Lidocaine is also a topical medication. I think we underuse topicals, at least in part because they're not covered by insurance, and people would prefer to have something that's covered by insurance. But they are definitely something you want to become familiar with. Glucosamine chondroitin is a dietary supplement. If you have somebody that has chronic joint pain, it may be worth a try. The general feeling is the role is unclear. I do see people that use it for animals. Is there a placebo effect if you use it with animals? Well, maybe if the owner thinks it's going to help. Maybe they perceive that it's going to help even if it doesn't. On the other hand, it does seem like the animals do behave better. The studies are actually less than impressive, but it's also possible that there may be certain people that have the enzyme and certain that don't. And the effect size is not large enough to be picked up in those studies. So what one of the nurse practitioners that works with the orthopedic group in Portland suggests is go out and buy the small bottle. If it's really working, go out and buy a big bottle. If it's not working by the end of the small bottle, well, it probably won't work with you. Some swear by this medication. Others really don't like it, but it's pretty safe and there's not really a lot of interactions or anything, so it's definitely something to consider. So that's the first talk. We'll go on to the second talk.